I hope everybody's doing well. This is Chief Cradle. We're getting ready to cover Disaster Medical Operations Part 2, which is your CERT Basic Training Unit 4. We'll cover a lot of material. We have about 58 slides to go through. So let's get started. It'll be over at least a little over an hour or near about. Let's review for a second. The three killers: airway obstruction, excessive bleeding, shock. How do you open an airway? Head tilt, chin lift. What do you do for excessive bleeding that's an arterial bleed? Direct pressure, tourniquet. Shock, keep them warm, get them care. Let's do the seat size, the CERT size up. Always remember that the CERT size up is a continual process. Number 1, gather facts. Number 2, assess damages. Number 3, consider possibilities. 4, assess your situation. 5, establish priorities. 6, make decisions. 7, develop a plan of action. Your plan of action comes from all 7, from the 6 things previously to the number 7. Number 8, take an action from your plan of action. Do the action, and then number 9 comes in, evaluate the process, and this continually goes on until the situation that you've been called to has been taken care of. Unit objectives for Unit 4. Take appropriate sanitation measures to help protect public health. Perform a head-to-toe assessment. Establish the treatment area. Apply splints to suspected fractures and sprains. Employ basic treatments for other injuries. Some topics we're going to talk about: public health considerations, functions of disaster medical operations, establishing medical treatment areas, how to perform or conduct a head-to-toe assessment, treating burns, wound care, treating fractures, dislocations, sprains, and strains, nasal injuries, treating cold-related injuries, treating heat-related injuries, bites and stings. So, what is public health? And what are some things we need to be considering when we talk about public health? Public health is the health of the public around you, whether it be your city, your town, your community, your state, your nation. One of the best ways we can to start preparing for and taking care of public health is to maintain proper hygiene. Maintain proper sanitation. Purify water if necessary. Preventing the spread of diseases. If we take public health into consideration and do these things, proper hygiene, wash our hands, brush our teeth, whatever that you can think of, maintain proper sanitation, make sure the trash is taken care of like it's supposed to be, purifying your water, you're doing all these things will actually help prevent the spread of disease. Maintaining hygiene. Wash your hands frequently. Excuse me. Or use an alcohol-based hand sanitizer. Wear non-latex examining gloves. Wear your N95 mask and goggles. Keep dressings sterile. Avoid contact with body fluids. If it's warm, wet, and not yours, don't touch it. Or I like to say, if it's wet and sticky and not yours, don't touch it. Whichever one. If it's warm, wet, and not yours, don't touch it. Or if it's wet and sticky and not yours, don't touch it. They're both good. Maintaining sanitation. Controlled disposal of bacterial sources. Put waste products in plastic bags. Tie the bags off and mark them as medical waste. If you have human waste, bury it. We actually have people during times of crisis that's their job, is to bury human waste. Water sanitation methods. Boil water for 1 minute. You can use water purification tablets. And if you don't have access to one of those and you want to do it a fast way, non-perfumed liquid bleach, Clorox, 8 drops to 1 gallon of water. If the water is cloudy, use 16 drops per gallon if the water is cloudy. Let it stand for 30 minutes. A lot of times you'll see us shake it up and then let it stand for 30 minutes. Functions of disaster medical operations. First one is triage, then triage, treatment, transport, morgue, supply. As you can see, all those AMR, American Medical Response vehicles on the bridge there, waiting to go into one of the cities down in New Orleans. So the functions of disaster medical operations is number one is to triage, then to treat, then to transport. If they don't need to be transported, but they need to go to the morgue, put them in the morgue, and then supply. How do you go about establishing and setting up a medical triage area, a medical treatment area? Select a site and set up treatment areas as soon as injured survivors are confirmed. When determining best location for treatment area, consider safety of rescuers and the survivors, and the most effective use of resources and how to get them in and out. So also how to get your vehicles, your ambulances, your fire trucks in and out to transport these patients to the hospital once you've started triaging them and treating them. Treatment area site selection. The site selected should be in a safe area, free of hazards and debris, upwind, uphill, and upstream if possible from the hazard zone. Upwind, uphill, upstream if possible from the hazard zone. And this must also be accessible by transportation vehicles, like I said before. And then it needs to be expandable if need to be. The picture there says it all. Most effective use of CERT resources. To help meet the challenges of limited resources, CERT may need to establish a decentralized medical treatment location, more than one location, and a centralized medical treatment location or one location. So it's up to your team leader or the incident commander for you to set up more than two treatment areas, more than one treatment area, or just one by itself. It's up to them to do it. Most places around here in your community, you can do one. If your community is large or has large areas to cover, you can have two. Then there's going to be 4 treatment areas within the area of treatment. I, or red, for intermediate. D for delayed, which will also usually be yellow. M for minor injuries or walking wounded, and that's going to be green. And then black for pieces that need to go to the morgue or that they're dead. Here's a nice picture of the layout. See the road coming in, so we can get your ambulances in and out. Treatment area layout should be organized in a, for instance, site, triage, transportation, and morgue. Your incident site, and then your triage area is going to be have your first 3, your red immediate, yellow delayed, green minor. Then the morgue should be off to the side. It also needs to be secured and make sure nobody can mess with the bodies, and also need to have an area that can cover them. Treatment area organization. Assign treatment leaders to each treatment area. Document thoroughly available identification information, description, age, sex, body build, estimate height, clothing, injuries, treatment, transfer location. If they're able to talk to you, also get their name. If they're not able to talk to you, do what it said: approximate age, sex, body build, estimated height, the clothing they're wearing, the injuries that they had, the treatment that was given, and where they were transported to. All these patients have to be followed up with. The head-to-toe assessment. Objective of the head-to-toe assessment is to determine the extent of injuries, determine the type of treatment needed, and then document those injuries. In the picture there, you have somebody at the head and somebody down there checking the feet. In class, you'll be taught how to do a thorough head-to-toe assessment, and you'll be looking for what is considered to be DCAP BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. And you can see a nice, good picture of each one of those things right there. It's really, really good. The deformity really looks good. Then you got your contusions, you got your abrasions, the road rash, got your punctures, got your burns, tenderness, lacerations, and swelling. Where and when. If it's light damage, assess in place. If there's moderate damage to wherever that you are, and then you found the patient, move the patient to the treatment area first, then do your assessment. Assess and tag everyone, both verbal and hands-on. So we will be talking about this in class. Conducting your head-to-toe assessment. You pay careful attention to everything. Look, listen, and feel. Look at the patient. Listen to the patient. Listen to the way the patient's breathing. Listen to the way the patient's talking. And then you need to feel the patient. Check own hands for patient bleeding. So as you're going down doing the checking, and I'll show you how to do this. Every once in a while you want to check head, neck, pull your hands out, look and make sure that you don't see any bleeding. Check PMS, pulse, motor, and sensory in all extremities. Checking for your pulses, you want to check, see if they have a pulse. At their wrist, on top of their foot. Motor, can they move it? Back and forth, up and down. Flex, extend. And then sensory, can they feel you touching it? Look for medical identification tags, whether it be a necklace, a bracelet, an anklet. And nowadays, a lot of times, runners have it on a watch they wear that has a red band on it, or some people actually have this information in their smartphone. Order of the assessment is going to be the head. In the head, you're looking for your DCAT BTLS, bumps, lumps, lacerations, and you'll feel all over the head, down through the hair to the scalp. Then you're going to go back to the back of the head or into the neck, and you go look for what we call step-offs or step-ons, any type of indention or an area that's actually extruding out of the neck area, which would be a neck fracture or a bulging disc. Once you get that, come around, you want to look at the front of the neck, and you want to make sure that the neck is also, the trachea is in midline with between the nose, the mouth, the trachea, and then your belly button. Once you do that, you're also going to come up and you're going to do the top of the head. Check the eyes for their pupils. Then you also want to check their nose for the mandible and maxilla. Then you want to go down, and you want to, that's when you go down and do the neck. Come around to the trachea, then you want to check the shoulders. Once you check the shoulders, you want to come down, you want to check the chest. You want to see if they have equal rise and fall of their breathing. Once you do that, then you also want to check their abdomen. You check their abdomen, and you're going to check the 4 quadrants. Then you go check their pelvis. Then you go check their legs. And you go check their arms. I know in the assessment here it says head, neck, shoulders, chest, arms, abdomen, pelvis, and legs. The one that you will be learning is head, neck, shoulders, chest, abdomen, pelvis, legs, and then arms. Then we'll roll them and do their back. Closed head, neck, and spinal injuries. Number one thing that we need to keep in mind is do no harm. Do no harm. Minimize movement of the head and the neck. Keep spine in a straight line. Stabilize the head. As you do your head to toe assessment, we'll be learning how to do this. Hold inline stabilization. Make sure they don't move when you talk to them. You want to keep their head straight ahead. Treating burns. Conduct through the size up. Treat with first aid. Cool the burn area. Once you cool the burn area, cover with a sterile cloth to reduce the risk of infection, or a dressing. Burn severity. Factors that affect burn severity. The temperature of the burning agent. How hot was it? Period of time the survivor was exposed. The area of the body of the survivor was affected. Size of the area burned, then the depth of the burn. All these come into play when we start looking at burn patients. So, different burn classifications and the pictures of those. You have superficial, which is just the epidermis, which is also known as a first-degree burn, like a sunburn, which is then goes to a partial thickness burn or second-degree burn, which is your dermis and your epidermis, which you can see when it starts bubbling up. You start having all the different blisters and everything. Then you have full thickness, so you might have heard that referred to as third-degree burns. The subcutaneous layers and all the layers above can be charred all the way down to even the bone. Burn treatment do's. When treating a burn survivor, do cool the skin or clothing if they're still hot. Cover the burn loosely with dry, sterile dressings and keep air out. Reduce pain and prevent infection. Elevate burned extremities. When treating a burn survivor, do not use ice. Do not apply antiseptic ointments or other remedies like mustard, butter, or mayonnaise. Do not apply these. Do not use ice. Do not apply butter. Do not apply mustard. Do not apply mayonnaise or antiseptic or ointments or other remedies that you might have heard your parents or grandparents talking about. If you can, remove shreds of tissue do not remove shreds of tissues. Do not break the blisters, or do not remove adhesive or adhered particles of clothing. So if you have areas of shredded tissue, leave them alone. Blisters, do not pop them. Or if you have any type of particles of clothing that's stuck to the patient, leave them in place. When we get them to the burn center gives them nice pain meds, and then get those take care of those things. Now, treatment for chemical burns. Remove cause of the burn, plus the affected clothing and jewelry. If irritant is dry, gently brush away as much as possible. Always brush away from the face, survivor, and you. Flush with lots of cool running water. Apply cool, wet compress to relieve pain. Cover the wound loosely with dry, sterile, or clean dressings. Treat for shock if possible. Inhalation burns, signs and symptoms. Burns to the face, the nasal passages, and the mouth. These patients can have sudden loss of consciousness, evidence of respiratory distress or upper airway obstruction. Soot, the black tarry-looking stuff around the nose and mouth. Singed facial hairs. Burns around the face and neck. A lot of times you'll also see this with different explosions. Wound care. Biggest thing we want to do for wound care is control bleeding, clean the wound, and apply dressings and bandages. Cleaning and bandaging wounds. Clean by irrigating with clean room temperature water. Never use hydrogen peroxide. Irrigate, but do not scrub. Once you clean the area, apply dressings and bandages. Dressings applied directly to the wound, and it can be sterile, preferably, and a bandage holds the dressing in place. That will be on a test question. Rules of dressing for active bleeding. Redness over existing dressing. If no active bleeding, remove bandage and the dressing to flush wound. Check for infection every 4 to 6 hours. So if there is active bleeding, redress over the existing dressing. So what they're saying is if the bleeding is bleeding through the dressing you have in place and the bandage, keep putting more dressing on it to try to stop the bleeding. If no active bleeding, remove the bandage and the dressing to flush the wound and check for infection every 4 to 6 hours. Signs of infection. Swelling around the wound site. Discoloration. A pussy discharge from the wound. Then red striations from wound site. Amputations. Means somebody did something and a part of their body is now missing. Hand, finger, toe, foot, leg, arm. Control the bleeding and treat for shock. If the amputated body part is found, safe tissue parts, wrapping clean material and place in a plastic bag. Keep the tissue parts cool, but not directly on ice. Keep the severed part with the survivor. Do not put the actual extremity or whatever it is on directly on the ice. That can cause frostbite, and then you might not be able to actually reattach the missing body part. Sorry if you hear my dog in the background. We're talking about impaled objects. When foreign objects are impaled in a patient's body, immobilize the affected body part. Do not attempt to move or remove the object. Try to control bleeding at the entrance wound. Clean and dress the wounds, making sure to stabilize the impaled object. Fractures, dislocations, sprains, and strains. Immobilize injuries and joints immediately above and below the injury site. If uncertain what type of injury, treat it as it's fractured. Splint it. We'll talk about splinting in class, and you actually get a lot of training with splinting. But if any uncertain injury type and it's an extremity, whether it be a fracture, dislocation, sprains, or strains, if you cannot tell what it is, treat it as a fracture and splint it. This is just different pictures of actual type fractures. You have a closed and open. An open fracture is where the bone is coming out of the skin, and a closed is where you can't see it. Treating open fractures. Do not draw exposed bone ends back into the tissue, so don't put it back in place, leave it where it is. Do not irrigate the wound. Cover wound with sterile dressing. Splint the fracture without disturbing the wound. Place moist dressing over the bone ends. This is your displaced and your non-displaced fractures. Same as an open, a displaced is going to be, the bone is actually off of its the center, and it's going to be either just off the actual bone, or it's going to be under it, or on top of the other part of it, and then your non-displaced bone is going to be in place of just a crack across the bone itself, but the bone is staying where it is. Dislocations. Dislocations is an injury to a ligament around a joint. So severe that it permits separation of the bone from its normal position in the joint. Treatment: immobilize it. Do not relocate it. Check PMS, pulse, motor, and sensory before and after splinting and immobilization. Dislocations, treat it like a fracture, splint it. Check your PMS before splinting and after splinting. Signs of a sprain: tenderness at the site, swelling and bruising, restricted use or loss of use. You see that nice picture there of the discoloration there and the bruising. Damaged vessels from the ankle sprain can cause bruising. Splinting. You'll learn a lot of different ways to splint in class. This is using a cardboard box. You can use a magazine, use a rolled up blanket. We'll have a lot of fun in class with splints. Splinting guidelines. Splint injury area above and below the injury. Rule of thumb is an area of your body that has two bones needs to have two boards. An area of one bone can have one board to splint it. Assess your PMS on the extremity prior to and after splinting. So assess pulse, motor, and sensory in the extremity. Splint injury in position that you find it. Don't try to realign the bones or joints. Fill voids to stabilize and immobilize. So if there's a void under an ankle, a lower back, fill it with a whatever you have to fill it with. Sheet, blanket, coat. Immobilize above and below the injury. Immobilize the joint if you can above and below. After splinting is done, reassess the pulse, motor, and sensory. Nasal injuries, nose injuries, causes blunt force to the nose, skull fractures. Non-trauma conditions can be sinus infection, high blood pressure, or bleeding disorders. This is going to be nasal injuries that cause somebody to bleed. Caution: large blood loss from a nosebleed can lead to shock. Actual blood loss may not be evident because the survivor will swallow some of the amount of the blood. So the treatment of a nasal injury: control the nasal bleeding, pinch nostrils, or put pressure on the upper lip under the nose. Have survivor sit with head forward, not backwards. Always make sure that the airway remains open and keep the survivor calm. Cold-related injuries, they're known as hypothermia, occurs when the body's temperature drops below normal. You have a frostbite. Occurs when extreme cold shuts down blood flow to the extremities, causing tissue death. Signs and symptoms of hypothermia: body temperature of 95 degrees Fahrenheit or lower, redness or blueness of skin, numbness and shivering, slurred speech, unpredictable behavior, then listlessness. The treatment for hypothermia: remove all wet clothing, wrap the survivor in a blanket. If you have one, put a space blanket on them. Protect the survivor from the weather. Provide food and drink to conscious survivors. Do not attempt to massage to warm the body. Place unconscious survivors in the recovery position. We'll talk about that in class. Place survivor in a warm bath, not a hot bath, warm bath. Then you have symptoms of frostbite. The skin is discolored, burning or tingling sensation in that extremity, partial or complete numbness. You might see swelling, which is also known as edema, and blisters, formation within 24 hours of frostbite injury. So do not bust those blisters either. Treatment for frostbite: immerse the injured area in warm, not hot water. Warm or rewarm slowly. Do not allow any part to refreeze. And do not attempt to use massaging. Do not massage the area. Just put it in the warm water and allow the warm water to actually warm the patient's extremity up. Wrap the affected body parts in dry, sterile dressings. Now I'm going to heat related. It's hot outside. Heat cramps, muscle spasms brought on by overexertion in extreme heat. Heat exhaustion occurs when exercising or working in extreme heat results in loss of body fluids. Then you have heat stroke. Survivor's temperature control system shuts down. The body's temperatures rise so high that brain damage and death may result or occur. Now think about this. As I am actually recording this, this is summer. It's about 93 to 94 degrees outside right now. Do you think a lot of people actually get heat-related injuries in this type of weather? Or do you think they actually get it more in the spring and fall when it's not as cold and when it's not as hot outside? Think about it. So what do you think? That'd be one of your questions you have to answer. Symptoms of heat exhaustion. You'll find the patient has cool, moist, pale, or flushed skin. Cool, moist, pale. Pale is going to be a whitish color or ashen, or flushed skin, which is going to be red. These patients will be sweating heavily. They'll probably have a headache. Might complain of nausea and vomiting. They might complain of being dizzy. They just feel tired. They're exhaustion. They're exhausted. Signs of a heat stroke. These patients are hot, red skin. They are not sweating. They are no longer sweating. The lack of perspiration. Changes in their consciousness. These people will mostly be somewhat out of it or unconscious. They'll also have a rapid, weak pulse and rapid, shallow breathing. Excuse me. Treatment for heat-related injuries. Number 1, remove from the heat to a cool environment. Cool the body slowly. Have the survivor drink water slowly. No food or drink if the survivor is experiencing vomiting, cramps, or losing consciousness. One of the ways you'll see us also do this, we'll take cold packs and wrap them up in a blanket or a towel, and we'll put it in under their armpits and their groin and the back of their neck. Treatment for bites and stings. If a bite or sting is suspected and the situation is non-emergency, remove the stinger if still present by scraping the edge of a credit card or other stiff, straight-edged object across the stinger. Like for bees. Wash the site thoroughly with soap and water. Place ice on the site for 10 minutes or on. Place ice on the site for 10 minutes on and 10 minutes off. Here again, you don't want it to be directly on the site. You want it to be covered up in whether it be like a towel or a washcloth, something like that. Then you have anaphylaxis. Anaphylaxis is a true emergency, and hopefully these people who know they have anaphylaxis or know they're allergic to something will have an EpiPen with them. Anaphylaxis, check airway and breathing. Calm the individual if you can. Remove any constrictive clothing and jewelry. Find and help administer the survivor's EpiPen. You'll have one of these in class. You'll pull the blue top off, put your thumb on top where the blue top just came from, and then you will administer it in their upper thigh and hold it in place until you hear a click, and hold it in place for 10 seconds. Take it straight out, rub the area or have them rub the area, and you want to watch for signs of shock and treat appropriately. In summary, public health concerns related to sanitation, hygiene, and water purification. You need to know about at least water purification, the number of drops of Clorox you want to put in for test-related issues. Organization of disaster medical operations, establishing treatment areas. You will be learning a lot and doing quite a few head-to-toe assessments. You'll be learning how to treat wounds, fractures, sprains, and other common injuries. So, homework. It's a little bit differently this time. Read the unit to be covered in the next session. Bring necessary supplies to the next session. Wear appropriate clothing to the next session. And then here is the change. I want you to, and I need you to, and you need to be doing this, practice complete head-to-toe assessment on friends and family members if they let you.